a lot of work has gone into the joint action. I think it's exceeded our expectations in terms of its ability to actually take work onto the ground, to actually be achieving change during the process of the joint action, rather than simply telling people how change could be achieved. And I guess what I was intending to do was just to say, talk again about the higher level outcomes, what we think the learning was from the process. We're going to have presentations from each of the different work streams, which will give a bit more detail and cover more about the substance of what went on within the individual work streams. And I'm very grateful for all of my colleagues who are here today to do that. This is largely the team that we started with at the beginning of the process, which is good. Didn't lose too many people along the way. Again shows the commitment that people have made over a number of years to take us to where we are. So, work package coordination team leader 1. These are the messages that we gave this morning, and I think I just wanted to reinforce them to give context to the presentations you're going to hear. So, again, the learning here is, while we think that we've been talking about reducing stigma, promoting inclusion and understanding dementia with clinicians and the public and people who work with dementia, now for many years, it was certainly one of the core elements of Scotland's first strategy. It's generally been the starting place to raise awareness and understanding. Our knowledge is that, based on what we saw through the joint action, this is work that you have to continue to do. In that, at the point where we've got the message about non-discrimination, inclusion, rights, there are many people who are well-intentioned, good clinicians, good care workers who still need that further work. So continuing to build on the educational and attitudinal work that we've been doing. Understanding the dynamics of change, and this doesn't just apply to dementia, understanding that where things have happened through the joint action across different parts of Europe, why Bulgaria has done this bit of work or why Italy has done that piece of work, it's because they were looking to solve what was a local problem or make a change which they thought would be valuable in their context. So while we're able to produce evidence, we're able to produce best practice, and we can explain why we think people should work in different ways, the choices that managers and clinicians make will be based on their local perception of change. And we can condition that to some degree, but it will ultimately come down to where this issue fits within their local priorities, because there's always more work that we could do than we've got the time to do. And the question is how we can ensure this sits within those priorities. Identifying how we can help people achieve their personal or systemic outcomes, understanding how what we're doing supports people in what it is that they want to achieve, but also understanding that and this is again where, Alzheimer Europe, local dementia associations, people living with dementia, as social movements have got the ability to change people's expectations about what they should want, that they should be looking for solutions, and this is the pressure that collectively we are able to put into the process to say, your historical narrative about how there's nothing we can do or there's no importance to diagnosis, that no longer holds good. We have the evidence, and it says diagnosis is important, post-diagnostic support is important. People can live good lives. There will be challenges, but there is value in delivering good care. Looking across the joint action, and you'll certainly pick up some of this, I think, through a number of the presentations here. When we do the same thing in different places, we get different results. And that's because it fits into highly complex health and care systems, which themselves are resistant to change. So we saw, certainly in the example I gave this morning, some of the work on education was picked up a lot more actively in Norway than it was in the Netherlands, but that was partly in the context that the Netherlands had a different way of solving the problem. And so this was seen as less applicable to what they were doing. Traditional roles and beliefs are a barrier to improvement, and I guess today, across a couple of conversations, again, we've seen how that operates, the idea that the clinician knows best, the idea that there are people with dementia require different styles of care. So I think understanding that, and again through the stigma work, that we're able to change how people understand how they should relate. The work between clinical teams, because our assessment is that clinical care works best as a combination between general and specialist, between nursing and psychologist, AHP and social care. So this is not unidimensional, and it needs to not be segregated, and that means teams need to value each other and the different contributions that they're able to make. Local leadership through the process has been the thing that has taken the individual tests of change to a conclusion. It's been the thing which has actually launched them, sustained them, and taken them through the process. And so one of the things that we need to do as we move forward is where people show that leadership, we need to recognize it so that others will see those who are doing well within the system. So we need to applaud the people who've stepped forward and said, I will take this project forward in my town, my municipality. As I said this morning, properly involving people living with dementia and their families is always a value and leads to outcomes better in line, more in line with their wishes. This was one of the messages that came out very much in the first year of the project, the work that was done around dementia-friendly communities, where there was a lot of pushback to frameworks and approaches which felt top-down, that felt imposed, that felt external, and a real need both to localise dementia-friendly in the context of particular communities, but also in the hopes and wishes of people with dementia and their families. And I think I think that's changed how we've seen dementia-friendly communities, and very powerful work done within England. Finally, and I guess this is my last message here, what we've seen is that even within a relatively short period of time of thinking about what to do, framing what to do, and seeking people to contribute, and setting something up and taking it into action, producing initial evaluation, you can do that relatively quickly, where you are motivated and engaged. So I would take the examples that we've got from the joint action as a corrective to the idea that if we want to do something, it's going to take a number of years. You can move to not doing something to doing something very quickly, and I think that should be the expectation that we have of our national governments, of our health delivery systems, and of our policymakers. I think it's no longer open to people to say that this is a complex and difficult area and that we need to consult and we need to engage. I think we should be expecting action and we should be expecting improvement, because the core message that we brought into this joint action was the way in which this needs to be judged is by the benefit it offers to people living with dementia and their families. It's not the degree of rigor of the production of the strategy document or the policy document. It's not the vision statement. It is about the day-to-day lives of people, and that's the only place at which change really makes a difference.